All right, so Dr. Trudy asked me to give this, it's basically a review of the primary and secondary survey. For those of you who routinely do trauma, I think this will be a very fundamental review. This is really intended for those who don't have to see a lot of trauma, but then sometimes it shows up. And just a refresh for what are the initial principles of managing these patients. Nothing to disclose. So we'll talk through some principles of initial trauma evaluation, specifically the primary survey, the secondary survey, and early resuscitation of the trauma patient, and some of the newest principles. So one of the key things to remember is the idea of the golden hour in trauma. There are certain injuries that take a patient's life at the scene, such as aortic transection or massive head trauma. But then there's a subset of injuries that, give or take a little bit, for about an hour, a patient can potentially survive. But it's really critical for the first responders or the initial physician evaluation that they identify those quickly and act on them, otherwise they can be lethal. And the most common of these that we'll see is tension pneumothorax, head trauma that is operative potentially, cavitary hemorrhage, or cardiac tamponade. And these are the things we're really looking to identify during this primary and secondary survey so that we can act quickly and save this patient. One of the things to think about when I'm talking through primary and secondary survey is how big your institution is and how you're responding. So there's a concept of a vertical resuscitation versus a horizontal resuscitation. We're a level 1 trauma center, so when a trauma patient comes in, there's about 14 of us in the room. So we don't really have to go through this in a linear fashion. We can all be working on different parts simultaneously. On the flip side, if you're at a smaller institution where a giant trauma team doesn't appear as if from nowhere and it's you and a couple other people helping you, you really just want to be very methodical and stepwise going through your primary and secondary survey. And that's how you make sure that you never miss anything. You check all the boxes and you're checking everything for this patient. And really you're dealing with one problem at a time. So additionally, if you're in a position where you're going to occasionally see traumas, it's nice if you can set up a system so that you're doing the same thing every time. Trauma surgeons are simple people. We want to see and think through the same thing every time, just so we never miss anything. So for us, this goes all the way up to the EMS report. When our EMS crew brings a patient in, we ask them to give us the data in the same way every time. In the literature, there's actually, the mnemonic is MIST. Don Jenkins, our former trauma medical director, thought it'd be more funny to call it VOMIT, and just gets everybody to think about it. So what we want to know is, what are the patient's vitals? Where's the patient coming from? That's particularly important for us. We're a relatively rural trauma center, so our transport times are quite long, and that helps us think about the patient and how far out they are from